First of all, we start with a roundtable. We'll ask all the panel, what's your favorite graft, the one you use in routine? We'll start with Thomas, for example, at the end of the class. What's your favorite graft? What is the one you use routinely?
For me, hamstring autograft, ST for the ACL and gracilis for the anterolateral ligament.
Pretty much the same. Non-athletes, semi-D and gracilis. Athletes, particularly football players, PTB.
Yeah, for me, it depends on the patient. So it's an individualized approach. For more sedentary, older people, then I tend to use a hamstring. But in the athlete and younger patients, then it's a 50-50 based on a trial that we're doing for BTB versus quadricep tendon.
For me, also an individualized approach. I mean, I live in America, so most of the grafts are patella tendon. We switched to quadriceps tendon a few years ago, and quadriceps is quite popular if you don't want to use the bone.
For me, hamstring, single bundle, and lateral tenodesis if there is a high laxity.
Pour moi, bone tendon bone, dans 95% des cas, pas de plastie antérolatérale systématique et plastie antérolatérale juste en cas de reprise.
Bon, l'approche individualised approach is mostly given by the sports or by the level of the athletes. Volker?
I think all of it together. So we individualize also by the size of the ACL, the native ACL, the notch size. We individualize by maybe the demand of the patient. If they do a lot of sprinting, is maybe different, or a carpenter who kneels a lot. So I think multiple factors go into it. And of course the question for failure rate, so there are many factors in this. Patella tendon seems to be very good.
Juan Carlos?
About the same. At least in Spain, it is impossible to do an ACL graft in a football player without using a PTB. They don't want another type of graft. The same for the females playing football, because they would play exactly alike the male's counterpart, so they would like the same graft. However, in my personal perspective, I think the graft is the less important point. The most important point is the technique. A good technique, I think, is mandatory, and the graft probably is less important.
Do the associated lesion important for you to decide what graft you will use? Alan? I mean, if you have a MCL or something like this, do you change your strategy?
So if I have an MCL, then I'll leave hamstring alone, not unless I'm reconstructing the MCL, in which case I'll often use the ipsilateral hamstring to reconstruct. But I'll be much more focused on using a BTB or a quad and an MCL lesion. Lateral side, I don't mind so much. With meniscal lesions, no. I mean, it's really being driven by age and activity level, which we've shown has been our highest predictors of re-injury. But then if you start looking at increased hyperlaxity, it's definitely an increased risk factor. General laxity in terms of anterior laxity, rotatory laxity, we know that that's an increased risk. And of course, tibial slope that we've talked about already this afternoon.
Thomas, tu fais une plastie extra-articulaire tout le temps?
Très bonne question.
Always an extra-articuloplasty in your practice? 100%?
Yes. Right now I am doing ALL for every patient because my main concern is about the re-rupture rate, and I have no side effect with ALL. So I started years ago by doing only athletes, high pivot shift, high risk patient, and with the time I have no side effects. So the question is why not to do it? And for that I have no answer, so I do it for every patient.
Are you stressed in life?
No. But when you see the rate of 10%, I think it's not acceptable to say that. So we have to reduce it, and I think it's much better to have 5 than 10.
Good. Good. I'll get good. You do 100% exarticuloplasty, and tell me about your stress, please.
No, I mean, it's challenging if you're focused. I would say if you're doing athletes and you're using your hamstring graft, and I'm sure if you look at the data, 80% of people in this room are probably using a hamstring as their primary graft. Then in the younger patient, you should be doing some sort of anterolateral procedure. I think that's very clear. The data regarding an extensor mechanism graft, be it a patella tendon or a quadricep tendon, is a little bit less clear. The failure rates are lower. And in those cases, I think there are certain patients that we probably can do without doing a lateral tenodesis. I just don't know which those patients are, and that's why we're doing another randomized trial to try and work that out.
Et toi, Guillaume, que fais-tu?
I would say 80% of lateral tenodesis or ALL reconstruction, because since 1 year, when I have a hamstring with a good gracilis, I use ALL reconstruction instead of lateral tenodesis with fascia lata.
And you always take your decision preoperatively or when you test it and test the patient under general anesthesia?
So it depends of the clinical examination before the surgery and the telos laxity. And if I have a high pivot shift, I say to the patient, I will do this lateral procedure. If I didn't talk to the patient about this procedure, I don't think it's a good idea to do it. And if there is no pivot shift or not a big laxity, I think there is a still place for isolated ACL.
For those who do ALL reconstruction or anterolateral procedure, do you check always the isometry, or are you sure of your positioning? Because Etienne and Thomas showed that it has a great influence on the behavior of the graft. Do you check it intraoperatively, Alan?
Sorry, did I check my isometricity?
Yeah, the isometry of the A and your anterolateral procedure. Do you check it?
My procedure is not isometric, so an LET is not isometric. So no, I don't check it. In fact, I want it to be non-isometric because it's a tenodesis. So
you're totally confident with the positioning? That was my question.
Yeah, because I go deep to the lateral collateral ligament, so it affectionately tensions in greater degrees of extension. So it's actually why it's so easy. You don't have to worry so much about your femoral insertion because the fulcrum's the epicondyle.
You change your rehab protocol depending on your graft or your exarticuloplasty?
Is that it?
Yes. In the past, we used just extraarticular tenodesis for revisions when I was young, I mean. Right now, we almost use extraarticular tenodesis for every single case. I think the problem is not the moment zero. You can test and retest the knee, but in general, the knee is okay at moment zero. Just after the construction, the main problem in my hands is the ratio of retear over time. And that's the reason for using any kind of extraarticular procedure. So I almost use it 100% of the cases extraarticular procedure. In my case, modified Lemaire.
And you, Volker?
I've used the tenodesis, obviously with the sort of the non-anatomic position, so it's not isometric. But it's very interesting. So when we do the tenodesis, you don't talk much about tension. I saw all the different videos today, some in extension, some more in flexion, some really high tension, low tension. When we did this study, I think this is a really interesting study that helped me understand it better. We did a randomized study and had patients run on a treadmill after the tenodesis 6 months and 12 months later. And I was worried when we designed the study. I'm like, should I use the ALL? So nobody would blame me on, trying to, make it look as no difference. But the interesting thing is a very low tension construct. Just like Andrew Amos showed in his lab, 20-some Newton, a very low tension construct. Much posteriorly translated those patients after 6 months. And then after 12 months, it stretched out and there was no more effect. I think it's very interesting because when do I use the tenodesis? I think when I'm worried about a patient not listening to me, going back to sports really, really early, where the graft, I mean, for us, the highest risk of graft re-tear is within the first 12 months. And that's probably where the tenodesis can really help. So in those patients where I'm really worried, I probably use the tenodesis. But like Al, I'm very curious about stability too.
Thomas, do you think the position of fixation of the anterolateral tenodesis is really matters? Is it 0? Is it 20? Is it 30 degrees flexion? You're the biomechanic guy.
Yeah, I think the good question is what you want to do. And we never play soccer at 90 degrees of flexion. So if you want to help your ICL in a good position, I think it's good to help your ICL in between 0 and 30 degrees of flexion, because you will run and play in this position. So basically, most of times the injury will happen in this kind of situation. So if you need to have something to help with the ACL, is in my opinion something in this range of motion.
I have a question, because when you use a lateral tenodesis like a deep Lemaire, it will be isometric, so you can fix at 90, 60, 30. I think it changed nothing. But when you use a ALL, it's completely non-isometric, and in flexion it will be a little bit loose. And I can see that at 20 degrees sometimes, or 30 degrees, but you don't know exactly the flexion of the knee at the time of the injury. So does it change something for you? Do you worry about that, or everything is okay?
No, I don't worry about it. I think I think the beauty about a deep Lemaire is that you don't have to worry so much about your position. And I occasionally do an ALL reconstruction. And if I'm doing an ALL reconstruction, I'm using a different graft. And I think if I went back to even the talk that Elvira gave, looking at the reconstruction that's been done in Lyon, I mean, that was a gracilis construct, a gracilis placed underneath the IT band. That probably behaves differently than a strip of a IT band underneath the lateral collateral ligament. So there are many nuances of what we were all doing. And I think you cannot just put them all into the same bucket and say that these are all going to behave in a similar manner. And so I think you choose what your technique is. And you understand what works. I mean, we've used the modification of the Lemaire for many years now, and we've shown in a level 1 study that it works very well, and we've shown it to be safe. We're now at the 7 years follow-up. We're not seeing an increased incidence of lateral compartment disease. We're not seeing a significant problem with hardware irritation. So data really drives your decision making. So I'm very happy with what we do. I feel it's safe, and we've studied that adequately. The question now is, do we need to add it into every single patient depending on different grafts?
A question about the coronal alignment. If you have a valgus knee, will you mostly you don't care, you take hamstring or BTB, or you will change the type of graft that you use?
That's a really interesting point. I think it depends on the patient you are dealing with. If the patient is really kind of active sports guy, probably you need to consider an osteotomy if the valgus is significant, because it can, help in the stability of the joint and in the future behavior of the joint. But with the technique, I really will not change anything. Probably I will take more care in the lateral side with the meniscus if it's a valgus, or in the medial side it's a big varus and so on. But I consider, particularly if it's a young guy with a long run in front of him, probably I would consider an osteotomy associated to the reconstruction procedure.
Other advice about that? Thomas?
No, it's exactly the same. We'll
On
not
s'en
change
fout?
my graft if it's a valgus or varus.
Al?
I think the important thing with any time you're assessing coronal plane alignment for me is symmetry. If you've got symmetric valgus, symmetric varus, then I don't worry. But if I've asymmetric valgus, then that may suggest that there may be some laxity on the medial side, in which case then it may be low-grade laxity, but it may be a problem, in which case I'm not going to touch the hamstring. So I think anytime I look at alignment, it's always got to be symmetrical. And in the primary scenario, to start doing osteotomies in the primary scenario when our failure rates are still relatively low, I think is a little bit too aggressive.
And I think there's a high concomitant MCL injuries and ACLs. We all know that, but maybe up to 30% or so. So I think the hamstring may not be the graft that I would choose for this. And same with respect to osteotomy, only if it's very much asymmetric. Or a revision setting, probably would consider that.
We've been discussing about what happens outside the notch, but do you care about the notch? Is it important for you? Do you perform notchplasty? Do you have a careful analysis of what you see intraoperatively, and do you sometimes perform something?
You know, interesting, years ago this paper came out that said 8 millimeters, the graft has to be 8 millimeters. If it is smaller, you have a higher failure risk. I don't think that's necessarily true for every. So if you have a really tiny notch, I don't think you want to put a 10 millimeter quadriceps in there. And maybe initially we did and didn't pay attention to it. So yes, the notch plays, I think, a huge role. So I would measure it, or at least have an idea. Also, technically, your surgery will be much more difficult, whether it's outside in or inside out, if the notch is small. So I would say it's less forgiving, probably a smaller graft, either 7 millimeter quad or even a 6 millimeter hamstring can work in that sense.
You know, both Volker and I are both in the process of randomizing patients in stability 2. And so we can have a 15-year-old girl on table and then be randomized to either a BTB or a quadricep tendon. And if they have a very narrow notch, that turns into a very, very different surgery for either of those two grafts. And so you have to be very mindful of that. And having a 9 millimeter or 10 millimeter diameter soft tissue graft in a very narrow notch is a problem. You may end up having to do notchplasties and various other issues. A patella tendon is fantastic because actually it's very flexible in terms of it can go into any size of notch. It's flat. You can rotate the bone plug so it sits nicely into that space. So I think those are some of the nuances of some of these graft techniques, and when you're doing individualized approaches, you have to be aware of these different pitfalls.
I think the notchplasty I would be careful with in a scenario where the notch is narrow and you may be tempted to do it. You know it will grow over. So just the placement has to be perfect.
Muchas gracias.